Previously on Dr. Boyev Talks at You. So there are 4 types of diabetes. Type 1, the insulin-producing cells in your pancreas are destroyed. In type 2, those are patients that are mostly obese. Those have insulin receptors that are no longer sensitive to insulin. Then there's gestational diabetes that usually occurs during pregnancy. And then there's drug-induced diabetes. You already know about that. That's with corticosteroids, atypical antipsychotics, thiazides, thyroid hormone, epinephrine, etc., etc. Patient with very high blood sugars can get into diabetic ketoacidosis. This is more common in type 1 diabetics. And that is a serious situation where they're going to end up in the intensive care unit, getting every 15-minute electrolyte checks, because the potassium levels can get crazy low. However, in hypoglycemia, all you need to do is give them some glucose or some glucagon and they'll be back on their feet. That's provided that the sugar wasn't too low for too long and the patient didn't have any bad underlying conditions. Type 1 diabetics have to be treated with insulin because their main problem is that they don't have insulin. Those patients must be treated with insulin and they must stick to a constant schedule of eating and exercise and administration of the insulin. That's because if you give them insulin and they don't eat, they'll end up like my cat on the front porch, all cold and stiff. In contrast, for type 2 diabetics, in almost every case, you're going to start with an oral drug, namely metformin, and insulin is only going to be added if the type 2 oral drugs and other injectables fail. Insulin is required because it promotes glucose transport into skeletal muscle and fat. It also promotes potassium uptake into muscles, which is again why you can't give giant boluses of insulin to people who in DKA. Let's talk about how insulin is administered. Well, one way it is not administered is PO. You can't put it in your mouth. Why is that? Because it's a protein, as shown here. If you put a protein in your mouth and swallow it, your stomach will start denaturing it and digesting it because proteins are yummy, yummy things that your body likes to eat. Therefore, insulin has to be injected or inhaled or brought into your body in some other way. And the most common form of administration is subcutaneous. Remember that if you're asking your patient to check their blood sugars 4 times a day, that means that they're jamming a needle into the end of their finger 4 times a day, getting a little drop of blood, putting it on the end of a little strip, and sticking that into a glucometer 4 times a day. That's uncomfortable. It's expensive because each strip is expensive. Just keep that in mind. Insulin regimens need to be tailored for each patient, and insulin comes in a variety of formulations. Fortunately, the American Diabetes Association comes out with recommendations and guidelines every couple of years. Now, normally patients take a basal, long-lasting insulin in combination with a short-acting form. The very rapid short-acting forms take care of peaks in blood glucose during and right after meals, and the longer-acting forms take care of the peaks in glucose that happen later in the day. Let's look at this chart, which shows the onset and peak activities of a variety of forms of insulin. Now, there's very fast-acting insulins like aspart insulin, and it starts working within 10 minutes. So that would be something you'd want to take within 10 minutes of starting to eat a meal. Then there's inhaled insulin, which also starts working pretty quickly. Now, please notice that this is different from an inhaled drug that you take for asthma, right? You take a drug for asthma, you inhale it, and it starts working right away because the site of action is at the lung. If you're taking inhaled insulin, the site of action is not the lung, so it's still going to take some time for it to start working because it is only entering the body through the lung, but then it still has to get through the bloodstream to get to its sites of action, which is going to be, skeletal muscle and fat, where it's going to be bringing glucose into those cells. Regular insulin is going to be having action about an hour later. And something like NPH, maybe you take the NPH insulin with breakfast, but it really is going to start working for your lunch meal. All right. Then long acting insulins like Detamir and Glargine, you would take once a day and they would work for 24 hours, just a basal level of insulin. Regular insulin is regular recombinant human insulin. This is a clear solution. You can give it via pretty much any route of administration, and it mixes well with the other forms of insulin. NPH is a mixture of insulin with a protein called protamine so that it dissolves more slowly, so it has a longer onset of action. Unlike the others, NPH is a cloudy suspension. We'll talk about that in a second. The more rapid-acting insulins also come as clear solutions that can be mixed with other insulins. Afrezza, which is the inhaled form, the only real contraindication is that if a patient has COPD or asthma, inhaling the Afrezza can trigger a bronchospasm event, so you need to be careful with that. Inhaled insulin, actually, there had been a form back in the early 2000s that sort of didn't sell well. And the problem was that you can't just use the inhaled insulin alone. It just doesn't work out. What you really need is to use the short-acting form in combination with a long-acting form like glargine, detameric, deglutic. The long-acting insulins also are clear, but you can't mix them in the same syringe with the other forms of insulin, which is sort of a drawback. In other words, that's going to be 2 sticks that the patient's going to have to take. As I mentioned, NPH, which is neutral protamine hagedorn, is a crystal of insulin plus a protein called protamine. And it comes as a suspension. It won't dissolve in water. So you have to resuspend it before you can dispense it. But you can't shake it because that'll destroy the insulin. So you have to gently roll it like a gentle lover's touch before you dispense it. Now, because it's cloudy, it might look as though it's somehow gone bad because you expect a lot of these solutions to be clear. Once you see it, and you just make sure you know what it looks like when it's normally cloudy. Once it's gone bad, it gets sort of a weird clumpy or frosty looking appearance. So how do these different forms of insulin work? Well, imagine, I've got a picture here. Imagine that these are 4 needles injecting into the subcutaneous space. And on the far left, we've got a very, very fast-acting insulin. I'm going to draw insulin as 2 little lines. That's going to be the 2 protein subunits of insulin. And the very, very fast-acting insulin comes just as single, sometimes as dimers of insulin. They get injected into the subcutaneous space or inhaled, dissolve into the tissues, binding receptors acting on their site of action. Great. Next, let's talk about regular insulin. Now, regular insulin usually comes in little bundles of 6, little hexamers that are clustered around a zinc molecule. I'm going to draw them as little trimers here because of the size of my pen. This slows down the absorption of insulin single units into the bloodstream and towards their site of actions, because the single units of insulin need to break away from the hexamers in order to get absorbed properly. In NPH insulin, we have the insulin stuck to a protein called protamine, and this slows down the ability of the single units of insulin to break away from this big glob and then enter the circulation and do their job. For the super long-acting forms, there's a variety of approaches. You can have a bunch of insulin stuck to fatty acids, and the fatty acids sort of glom onto everything, including albumin in the bloodstream, and that slows down absorption. But my favorite one is glargine, which just has tons of these insulin hexamers, again, each one surrounding a zinc ion, all crystallized together into a big blob like this. And that, of course, slows down the absorption because the insulin that's on the very inside of the big blob gets absorbed last. So this makes the absorption profile very long. Now, in terms of insulin delivery devices, we have standard insulin syringes, insulin pens, jet injectors, and insulin pumps. Here's an example of an insulin syringe. Now, this is one of my old insulin syringes from my pet cat. So this is called a U40. These are pretty much only used in veterinary medicines. But that's the example that I had on hand. Most human syringes are U100s, and they're the same in that the little marks on the syringe tell you the number of units that you've drawn up. So it's very simple for patients to know exactly how many units you've drawn up. Now, these syringes are very tiny, and if you are somebody with diabetes and maybe you have a little bit of diabetic eye disease, it makes it pretty tough for you to know exactly how much you've drawn up. So that's where insulin pens come in really handy. Insulin pens help with this because you can dial in your dose, or you can have a caregiver dial in the dose, and then it's just a matter of pushing a button to deliver the dose. Also, the pens are nice because they're a little more discreet. You don't have to carry around needles and bottles to work. You can just have this little thing that looks like a pen. Some pens are even controlled by apps on your smartphone, which is pretty cool. There also exist jet injectors, which don't use a needle, but rather using compressed air blow the insulin through the skin. But evidently this is more painful than a needle, and it is not as precise because the injector tip has to be cleaned more regularly. Last, there are insulin pumps, which do the work of all those injections the patients usually would have to do. These consist of a glucose monitor as well as the pump itself. Some of these are even attached to apps, which is really nice for parents of type 1 diabetics so that they can be monitoring the blood glucose and insulin injections of kids while they're at school remotely. It's good for peace of mind. What about the timing of these doses? Well, you could do it the old-fashioned way, like the 1990s. This is a hospital order I remember writing many, many times, which is the nurses would check a blood glucose level, and depending on what the level was, you'd give them some regular insulin and then be done with it. And if the level was over 350, they would call the intern and we would deal with it. Well, obviously, this is a terribly sloppy way of doing it. Since then, there have been some modifications to this, which was called the sliding scale. You could say, well, if a patient was very insulin sensitive, you could give them a little bit less each time. If they were very insulin resistant, you give them a little more each time. Then people said, well, you really shouldn't give them this much insulin if they're right about to go to bed, which is what HS means right before bed. But this is still super sloppy, right? And granted, this is in the hospital, not when a patient's at home. However, there were a bunch of studies that showed that patient survival and how well they did in the hospital and even afterwards was really affected by how much their blood sugars bounced around when they were in the hospital. So it became increasingly clear that doing these sloppy sliding scales is not sufficient. And in the 2021 ADA recommendations, it was recommended that sliding scales alone are not enough anymore when a patient's in the hospital. Each patient who has diabetes needs a diabetes team or specialist to be working on them. And of course, you can't do something like this sliding scale because every patient is going to have a totally different situation depending on what time of day the glucose is taken, what their underlying conditions are, how sick they are, why they're there. Are they there just for surgery, or are they there because they got hit by a car? What other drugs they're on, et cetera, et cetera. Okay, let's talk about the timing of doses for reals now. First, let's look at what the body does. If a patient is eating breakfast, lunch, supper, and a bedtime snack, the body releases insulin in response to the blood sugars going up. The person eats, insulin is released for each one of those situations. Well, for us mere mortals, we have to give the insulin first, and then the patient eats, because the insulin has to have time to be absorbed into the bloodstream. For patients that are having to give themselves injections, the most convenient way to do it is to use a mix of 70-30, usually a longer-acting NPH type mixture, plus 30% regular or fast-acting insulin, only twice a day. So the mixture will cover the meal that they're about to eat plus the next meal. Now that's quite convenient, especially if you have a pen that's already pre-mixed with the 70-30 mixture. Now, if you have a patient that doesn't have regular eating habits, you might be better off with multiple injections of very short-acting insulins that can be tailored for the size of the meals or the time of the meals. And that can work also with the pump, because the bolus injections that happen before meals are controlled by the user. So again, each one of these schedules have to be tailored for each patient. The last complicated thing I want to talk about is the Somogyi effect and the dawn effect, which are sort of related. I can tell you a story of a fellow that came in with his daughter, and the daughter was yelling at her dad and saying to me, look, you have to tell him that he has to stop cheating on his diabetic diet. I might as well just put a lock on the refrigerator. I know he's going down in the middle of the night and eating, and because in the morning his blood sugars are so high. And he just looked at me and said, look, I'm not cheating. I promise. And what was happening was that actually it was just that his bedtime dose of insulin was a little bit too high, and his bedtime snack was a little bit too low in calories, because what was happening was his blood sugar was getting a little bit too low while he was sleeping, and that was kicking in some glycogenolysis, right? Some breakdown of glycogen in his liver to compensate for the mild hypoglycemia he was having while he was sleeping. So there is something called the dawn effect, which is where right before you wake up, normally cortisol helps stimulate blood sugar levels to go up. That's so that you're ready to go when you wake up. And this was being sort of overstimulated in this fellow. That's called the Somogyi effect, which is if you get a little bit hypoglycemic while you're asleep, you'll wake up with a high blood sugar. So that was what was happening with this patient, and all we had to do was lower his bedtime dose of insulin, and he was okay. Finish up here to just remind you that the dreaded effect of insulin is hypoglycemia. The patient absolutely must eat after taking their insulin. Other side effects include lipodystrophy, which is a little dimpling where the injection takes place because the fat can sort of melt away underneath where the insulin was injected, which will happen if they don't rotate where they inject. That doesn't mean they rotate the needle. It means they move where they've injected the needle. Also, hypokalemia can be an issue. Allergy is really no longer an issue because all the insulins are recombinant human insulin. However, rarely patients are allergic to the protamine that are in the NPH formulations. Last, I want to address something that's in the recommendations, and it has been for a little while, and that is when to consider less intense treatment. That is, when do you decide that you're not going to target HbA1c level of less than 7%? And that might be in a situation where you really, really don't want the patient to get hypoglycemic. Maybe they have advanced complications like bad angina, and a hypoglycemic episode might lead to a myocardial infarction. Maybe they have a history of severe hypoglycemia, and that they have a tendency to do that. Maybe there's psychosocial issues, like they live alone, and if they became hypoglycemic, they'd just lie on the floor till their cats ate their face. Maybe that they don't adhere to the recommendations you gave them, and they don't eat after they take their insulin. Then there's the old limited life expectancy question, which I always feel ethically uneasy about, because who decides when you're going to live or die? But that's something you can wrestle with yourself. Regardless of what you decide, make sure you discuss this with the patient and tell them the relative risks if you worry about hypoglycemia. And this is not only true for insulin, but also the oral hypoglycemics like the secretagogues. And we'll talk about that in the next part of this 3-part series about diabetes, and that'll be drugs for type 2 diabetes.